Good afternoon, everybody. This is Sonia Denisenko, the manager of the Victorian Stroke Clinical Network, and I'd like to welcome you all to our March Stroke webinar. Today's webinar we have Dr. Tamara C. speaking. Tamara is a Grade 4 occupational therapist who has co-junct appointments at both St. Vincent's Hospital and also Latrobe University. Tamara completed her PhD in 2015 and spent that time looking at issues relating to participation after stroke, and that's the basis for today's talk. We will be conducting a number of polls throughout the presentation where you'll be able to ask to provide feedback and input, and at the end of the talk we will open the floor to questions. So as we're going through, please do type your questions into the blog site on the side of your screen, and we'll collate those questions and ask them of Tamara at the end. If you do need technical support, please dial the 1800 number, and we do expect a great attendance this afternoon, so we hope as many people as possible can complete the exit survey so that we can monitor and get feedback from you and also ascertain how many people were actually listening in today. So again, I'd like to welcome Dr. Tamara C. and thank her for providing our March VSCN webinar.
Thank you, Sonia, and thanks for inviting me today to come and speak about my research. I'm delighted to be here and to share with you my work over the last few years. So my presentation is a summary of the work I've been doing over the last 6 years. And as Sonia said, it was in combination with my work at Latrobe University and the Florey Institute of Neuroscience and Mental Health. And it was in the stroke division under the lead of Leanne Carey in the team of the Neurorehabilitation and Recovery. So the focus of my talk today is on participation after stroke. What is it and why is it important after stroke? But before we move on, I'd just like to mention my affiliation. So there's Latrobe University, the Florey, and I also have an affiliation at St. Vincent's Hospital in Melbourne. Now to begin, I would like to ask you all a couple of questions via the online poll, just to get an idea of your understanding of your knowledge of participation prior to my talk. So my first question is up there now. So it is, what is the ICF definition of participation? And it's a multiple choice question. So I can see, yep, we've got quite a few responses, so thank you. So yes, the majority of the responses did lean towards A, which is involvement in a life situation, and that's correct. But also, the action of taking part is actually a term, a definition of participation, but it's not the ICF definition of participation. So my next question, my next poll question that I'd like to put up there is, which of the following are measures of participation? And just be mindful there that there is more than one correct answer. So I can see quite a few coming in terms of the stroke impact scale, the work and social adjustment scale, and the activity card sort, and one for the modified Rankin scale. Yep, and they're all correct. The other one too, even though we're, when you're looking at the French Activity Index, it is actually considered a measure of participation as well, even though it does tend to lean towards more activities rather than participation. But I'll talk through that as we move on. So my first slide, yes, what is participation? So at the beginning when I started my journey through my research, I thought as an occupational therapist I knew what participation was. And then as I delved further into it, I became more and more confused. And so just realizing that there are many different professionals that come to this concept of participation, and they come with many different theoretical underpinnings and models. different theoretical frameworks and conceptualizations. So it really called for what's called a theoretical concept analysis, and I based my theoretical concept analysis on the work by Avant and Walker. And it's a iterative process where you first of all select the concept, and of course mine was what is participation. You determine the research question, and then you identify the uses of this concept and come up with a defining definition of the concept, or you determine the defining attributes of the concept that you're looking at. So my question was, what is participation and how is it conceptualized in the adult rehabilitation health literature? So there's my research question. And so the first thing, or the next step, is to look at how it's being used. So as you can see there, I conducted a literature search and I used the databases that I've listed there. I also did a number of hand searches, so went to the library catalogues, did some web searches and looked up the key organisations that talk about participation, so being the World Health Organisation in terms of the ICF, and I looked up the WFET, so the World Federation of Occupational Therapy, and a number of other key organisations. So the data that I included were case studies, cohort studies, randomised controlled trials, qualitative studies, systematic reviews, looked at also commentaries and governmental publications and books. And so from all that data searching, there were over 1,000 different references that were looking at the term participation. I screened most of them in terms of my question and found that there were 57 that were eligible that I included in my concept analysis. And identified that there were 4 key concepts of participation. The most common one being the ICF, and as I used in the poll, the definition of participation from the ICF is a person's involvement in a life situation, and also that it represents the societal perspective of functioning. The next concept comes from a more social perspective, called social participation, and the key defining feature of social participation is that it's an involvement with another person in a social activity. Then we come to community participation, and this really is more about community capacity and community development rather than, so it takes the idea of participation away from the individual and puts it really out there in the community, and what is the community, how does the community foster participation? And the last one being occupational participation. So this is around engagement in daily occupations of life, families, work and communities. So from those 4 concepts of participation, you can see there are different types or focuses of participation, but there is no doubt that regardless of the type of participation, what a person participates in is influenced either as an enabler or a restrictor by the person's interest, the person's usual habits and routines, the person's past experience, their age, gender, lifestyle, culture and social environment. Often terms used to refer to these are factors such as contextual factors in the ICF, or socio-cultural factors, environmental factors and person factors. Oh, sorry, just go back a bit. So, so combining these concepts and factors, the definition of participation derived from this concept analysis is participation is doing what one wants and needs to do, where doing encapsulates being actively engaged or involved in what one wants and needs to do and integrates the influence of the contextual factors at an individual, community and societal level. So the key elements here are about it's what one wants and needs to do, and it's more than just at the societal level, it's also at the individual level and the community level. So the next part, in terms of this research, I looked at what were the concepts of participation, and now the next step was to look at how participation was being measured. So I've popped up a paper that I published in 2013, and it was a systematic review that I conducted to try and find out how was participation being measured after stroke. So the research question, or the aim I've popped up there, was to identify and critique the measures currently used to assess participation in clinical stroke trials. And again, used a database search. I also so from the database search, I found the tools that were most commonly out there that assessed participation. I evaluated the psychometric properties of, the psychometric properties of the most frequently used participation measures, and then I linked those participation measures to the ICF activities and participation domains. But I'll go into that now in a little bit more detail. So you can see up there, this is just the flow chart of how I got to all the studies that were using participation measures. So I've just listed the search terms up there, so stroke, participation, evaluate, assess and measurement. I used Medline, CNAL and ProQuest Central, and I included case studies, cohort studies and randomised controlled trials. And I searched this data between 2000 and April 2012. I restricted the hits that I got to peer-reviewed journals, took out any duplications, and I took out any validation studies because I was really interested in what was currently being conducted at the clinical trials level, not at the validation stage. So the final number was 119 studies that were using participation measures across that over that period of time. So from those 119 studies, there were 36 different participation measures out there. But the most frequently used ones I've listed there, and they were the Stroke Impact Scale, the London Handicap Scale, the Assessment of Life Habits, or the LifeH, the French Activity Index, and the Activity Card Sort. And they accounted to around, I think it was 56% of all the participation measures that were used in that that data set or those 119 studies that I found. So as I mentioned before, I wanted to look at how reliable and valid the measures that I found were in terms of their psychometric properties. So I set, there were 5 different criteria that I had. So there was, as you can see there was inter-rater reliability, internal consistency, retest reliability, content and face validity, and construct validity. And of these, the London Handicap Scale and the Activity Card Sort were the measures that met 3 out of the 5 criteria. The LifeH and the French Activity Index had 2, and the Stroke Impact Scale only met 1 of the criteria. So the next step was, another way to look at what measures assess is to link them to the ICF. So the ICF is a framework that can be used to support a systematic approach to understanding chronic illness and disease across a culture. So the aim of the ICF is to provide a unified and standardised language and framework for understanding and communicating health states. So I've put up the well-known figure that depicts the ICF, and you'll see there that there's the ICF is organised in 2 parts. So one part deals with functioning and disability, and the other part deals with the contextual factors, so they being the environmental factors and the personal factors. So part 1 consists of the body component, so that's the body functions and structure, and then the second part is the participation and activities. So this is what I linked the participation measures that I found to. And I've just listed there the domains. So there were 3 independent raters, but we linked them to the first and second level of the ICF activity and participation domains, but I'm just listing up the first level there because it's just too big otherwise. And as I said, there were 3 independent raters, and we followed the rules developed by Chesa in 2005. So what we had to do was, for every item in each of the measures, those 5 measures that I mentioned before, we had to identify the meaningful concept and then link that meaningful concept to the most appropriate category or domain in the ICF. And so what we found was that in terms of the 5 measures that I mentioned before, the stroke impact scale, the life H, and the activity card sort covered the most domains across the ICF. But you'll see there that 26 of the domains from the stroke impact scale, or 26 of the items linked to the ICF, were outside the activities and participation domain. And the domains that were covered most frequently were the community, social and civic life, domestic life, and mobility. So just in conclusion to those parts, I mean the measures, the most frequently used tools, as I said before, were the stroke impact scale, the London handicap scale, the life H, the French A, and the activity card sort. But there wasn't one tool that met all the psychometric criteria. And as I just mentioned, the most frequently linked domains were community, social and civic life, domestic life and mobility. And the least items that were linked to the ICF were learning and applied knowledge, general tasks and demands and communication. So actually before we move on to this, we've got our next poll question. So the poll question that I've put up here is, do you currently use a participation measure in your work? So we've got that most, so 81% being on 82, no. Okay, I just wanted to know. So I've got another question coming up after the next chunk of slides. So we'll move on. So the activity card sort was the measure that we decided to use in our clinical trial. So the activity card sort is has been adapted to an Australian population, and there are 82 pictures that the participants are given to sort out into categories that they either haven't done prior to their injury or illness, and in this case it was stroke. They continue to do after their stroke. They've given them up. They're beginning to do their activity again, or it's a new activity. And scores are calculated to get a score of percentage of retained activity participation as a whole, but also in terms of the domains of leisure, social educational activities and household activities. So then we'll move on to the clinical trial that I conducted, and this clinical the clinical trial that formed part of my research was nested within this larger study that comes under the START umbrella. And I'll just read out this the design of the START study just because I like to read it out, and it says the type of design it was a mixed method, randomized, multi-centered, double-blinded, stratified, placebo-controlled phase 3 RCT within a larger cohort study of ischemic stroke patients. So it's a mouthful, but it's interesting to have all those names and terms. But just in terms of what I was looking at, so participants were recruited either through the START Extend study or the START Prepare study. So they either were recruited within 4.5 to 9 hours of having a stroke, or up to 3 days if they were recruited through the Start Prepare Standalone study. So the pool of people that I had were considered within that START cohort. So we had altogether 19 Australian and New Zealand sites that formed part of the overall study, or clinical trial I should say. And so this is one of the outcomes that have been published just this year, so it's quite exciting. And it was looking at retained participation and its association with depressive symptoms 3 months after stroke. So I've just popped up the aim of the study there. So it was to investigate changes in participation after stroke and the influence of depression in an Australian cohort. And so my questions were, what was the extent of retained activity participation 3 months after stroke? And were depressive symptoms associated with retained activity participation? So it was a cross-sectional study at 3 months, and we had 100 stroke survivors, and the analysis that I used was a multiple median regression analysis. I used very well-known and valid measures. There was the NIH stroke scale assessment that we assessed at day 3, and then the mood questionnaire or the depression questionnaire was the Montgomery Asberg Depression Rating Scale, and as I mentioned before, the activity card sort. So overall, you'll see I've just got a slide up there that shows the participants that were part of this study, and you can see there that their mean age was 66. We mainly had males, so there was only 28% females. Most people were living at home, most were married, but you'll see there in terms of their stroke severity, the median stroke severity score was 1, which really implies very, very mild stroke survivors, cohort of stroke survivors. The depression MADRS score, the median was 1.5, so overall, sorry, not 1, 4.5. So overall, not the group on average, we're not depressed. But then when we look at participation, 97%. People had, or the participants had returned to 97 on average, or the median was 97% of their previous activities. So when we look at the results, these are the results. So what this is saying is that there was a significant negative association between the MADRS scores, or the depressive symptom scores, and percentage of retained activity participation. So what that means is that with an increase of depressive symptoms, there was a decrease, so that negative association, when one score goes up, the other score goes down. So with an increase of depressive symptoms, the percentage of retained activity participation went down. And when we unpack those figures, what that actually means is that so an increase in one depressive symptom was associated with doing less one activity or returning to one less activity 3 months post-stroke. And what we also found, because we looked at current activity participation levels, so what people were also, so not only what they retained in terms of pre-stroke, but also what they were doing at 3 months, so their current activity level. And we also found that one depressive symptom was significantly associated with doing one less activity. So so engaging in one less activity as well. So very similar results in terms of percentage of retained activity participation and current activity participation. So that's the table of results that I was just talking about. So I've presented the quantitative outcomes of that clinical trial, but I was also interested in understanding what were stroke survivors' reasons for doing, and also the changes in their reasons for participating at 3 months post-stroke. So I also conducted a qualitative study, and I used the activity card sort to base my questions in, as well as using a semi-structured interview. And I know that's really small writing, but I just wanted to get an idea of what people were doing and whether things had changed, particularly in terms of their leisure activities, their household activities, and their social activities. And in summary, there were 3 main concepts that came from this qualitative analysis. And so as I've put up there was the personal dimension, the temporal dimension, and the environmental dimension. So at 3 months, stroke survivors' reasons for activity participation involved participants orchestrating a dynamic mix of fulfilling their personal desires, so their personal dimension, according to their current functioning and their social and physical environments, as well as their routines and their need to occupy time. When I asked participants about their change in participation 3 months after stroke, there were 13 participants that reported their reasons for doing their activities had changed since their stroke. And when I asked the participants to elaborate on their changes in reason for doing, there were 3 other categories that came up. These were I can't, change in environment, and I need time to recover. So I can't related to the physical, cognitive and mental changes after stroke that impacted on the participants' participation. Change in environment included changes in social and physical environment, and this included the institutional factors such as doctors' recommendations and regulations that said a participant could not do certain things after a stroke, such as driving or returning to work, and also being told to give yourself 3 months before you start doing everything again. There was also a temporal dimension, and this was associated with returning to participation. I need time to recover. Participants spoke about wanting to return to their previous activities, saying absolutely, or I'd like to if possible, demonstrating that they had hoped to return to their previous activities, but that perhaps at 3 months it was a little bit too early to be doing everything yet. So I just wanted to read out one comment from one of my participants that I've named Jim, and he says, I don't want to jump in too quickly. And that aptly summarised this temporal dimension, that it is necessary for participants to be at the right time to return to the activities they were doing, all the activities that they were doing before. So when I looked at the activities participants had given up, the most activities given up were ones that took people away from the home. The activities given up were more physically active and community-based, whereas those activities that the participants had retained tended to be ones that were more home-based. And as I said before, all participants wanted to get back to doing all the activities they were doing at 3 months post-stroke. So just in conclusion to this part, so one of the main key take-home messages is that we really need to identify factors such as depressive symptoms, because these have been shown to influence activity participation, particularly at that early stage. And that people's reasons for doing and reasons for change are complex and dynamic. The other key take-home message is that clients' perspective of their health is really important, but it's something that's not often, it's often neglected and not often incorporated into individualized therapy. So now if we move on to the next part, which is why is it important? Why is participation important? And this is another study that was conducted by a master's student of mine, and it was looking at factors that impact quality of life after stroke at 3 months and 12 months. And actually, before I go on, it's just been accepted, so as a for publication. So we're quite excited in topics of stroke. So that will be coming out soon. So what in terms of this study, the aim was to look at the impact of several different factors, being disability, cognitive function, depressive symptoms, physical activity, and work and social engagement on quality of life in an Australian cohort, again, at 3 and 12 months. And we adjusted for age and gender as well. And so the methods we used, so the data analysis we used was quantile regression analysis, and it was a two-step process where we identified the independent associations between those factors I listed before and each domain of the stroke impact scale. And then those factors that were significant we included into the multivariable regression. And as we've listed there, using SPSS and Stata. And the main results and conclusion is that engaging or returning to work and social activities was an important factor associated with stroke-specific quality of life, particularly in terms of physical function, participation, perceived recovery, and emotions. So overall, my take-home message is, in terms of participation, what is it? The key message, as I mentioned at the start of my talk, was that doing what you want and need to be able to do. But it is also nested within the individual context and or the environmental context. So at the individual level, the societal level, and the community level. And why is it important? Because it's associated with depressive symptoms and also quality of life, even in a mild stroke population, which were, as I mentioned, were part of our cohort study. My next take-home message is that change in meaning is important to recognise. So when participants perhaps, or when stroke survivors perhaps are changing what they're doing, it's important to understand the change in the meaning rather than just whether they're continuing or not. There's one example of one of my participants who moved home or changed residence, so he was no longer living on his own and was living with a friend. And so when we were looking at the activity card sort, it looked like he'd given up a lot of activities since his stroke, but in fact it wasn't to do with his level of or his impairments. It was more to do with his environmental changes. So it's really important to understand all those contextual factors as well. And the last take-home message that I wanted to just mention here was that the given up activities, the activities that take people away from the home, they're the ones that were given up the most, and the ones that were attained the most were the ones that people could do at home. And this was at 3 months. So perhaps this is something that we need to consider in terms of our therapies at 3 months post-stroke. So the next steps in terms of where I'm heading with my my research, I'm wanting to look at the 12-month relationships between mood and participation at 12 months. We're conducting an exploratory factor analysis, so that's where we're putting together the different measures that we've used in our studies. We've had the stroke impact scale, the work and social adjustment scale, and the activity card sort. So we're looking to see whether quantitative, we're able to say something about what these measures are actually measuring. There's a number of collaborations and pooled data that we're doing. So I've got some collaborations in the States with Carolyn Bohm and also in the Netherlands with Carolyn van Houten. And we're trying to put our participation measures together, and again to look at perhaps a confirmatory factor analysis in terms of what is participation measuring. Also looking at recovery and trajectory of participation over time. And the last thing I wanted to put up there too is that as part of my work at St Vincent's and the work that Chris Graven has done and Kim Brock is the development of the chronic stroke review tool, the intervention. So it's a chronic stroke review and intervention tool. And I know Kim presented a talk through the Victorian Stroke Clinical Network, I think it was last year. So I've just put up that video there. But we're also presenting this, the chronic stroke review tool at the Allied Health Conference on Friday. Now, so that's my last slide, but before we finish, I wanted to just do the last 2 poll questions. So do you think measuring participation is an important outcome for your service? So I'm glad we're getting yes, and it's almost 100%. So that confirms my interest and my research, and I suppose also your interest out there as well. And the last poll question. Oh, sorry, no, that was the last one. Sorry, yes, made a mistake. So I just wanted to pop up my acknowledgements, so the participants that participated in all our studies, my supervisors, the team from the Florey, as well as the start recruiting sites that I've mentioned there. And lastly, questions.
Thanks, Tamara. So please do enter any questions that you have in the question box, and we will discuss those. And also we should have our exit survey popping up shortly as well. We'd really like you to take the time to complete that survey, and particularly if you were sitting in a group or listening to the webinar as part of a team, we'd really appreciate knowing more about how many participants you had, so we can track how many people are interested in these webinars. So as we're waiting for some questions to come through tomorrow, I just wanted to perhaps get a little bit more idea from you about the shift perhaps for stroke patients if they've had their stroke while they're still working, and the change in going from an employed state versus those participants that may have been retired already. Was there a difference in your subjects, or were they all already retired when they had their stroke? Do you know?
No, it was quite interesting. I've looked quite in detail at the participants who were in the qualitative study. So they were the 30, and interestingly, half of the participants were working before their stroke, and of those that had returned to working, their average age was 68. So they were an older population. So I suppose it made me think that I suppose we all come with assumptions, so it makes me just think that just because of someone's age and just because they've had a stroke doesn't mean that they can't return to work. So that was quite interesting. In terms of those, because you mentioned those who had died, just overall, because in the as I said before, the study that I had nested my PhD within was part of a larger study. We only, in terms of the study, my PhD, we only had one person who died after their stroke. But in terms of the larger study, which included those 15 sites and a New Zealand site, I think there was something, it wasn't that high, and I think it was maybe 15 to 20 people that had died. And we're working through those that had returned to work, so particularly in terms of the return to work scale, the work and social adjustment scale, that's something that we're wanting to look at 12 months as well.
Mm-hmm.
Yeah.
Okay, and tell us a little bit more about the magic number around 3 months and the fact that everyone's waiting for 3 months and something's going to be different at 3 months. And even with the Australian Stroke Clinical Registry, we collect outcome data at 3 months. Do you feel like the changes for people at that point are more psychological than physical? Like I just would like you to unpack a little bit more. Why is there this line in the sand at 3 months that I can do it before that? I can't do it before that, but I might be able to do it after.
Yeah, that's really interesting, and it's something that we often talk about. Why is it that we have these 3-month markers? We do know that people that recovery perhaps can occur, or does occur more at those earlier time points, but that doesn't mean that it can't after 3 months. So there isn't like this miraculous divide between those pre-3 months and those that after 3 months, because we do find that people can regain their lots of different impairments after 3 months. So in terms of that being a psychological time point, particularly in the participants that I looked at, I think yes, it was definitely. And there were even people that said, well, I'm just waiting for 3 months before I actually start to even try it, even though, and I would ask them, well, why are you waiting? And they would say, oh, even though I know I can do it, I just don't want to do that just yet until I get the okay from their GP or their 3-month follow-up at the hospital.
Right.
So I think there's a lot to be said about that 3-month psychological time point as well.
Yeah, that's really interesting. And we've had a question here about outcome measures. So can you talk to us a little bit more about what the best outcome measures to use in rehab are for quantifying participation and depression, if you know a little bit more about that?
Yeah, I think I lean towards the activity card sort, because I think it's a measure that you can do quite quickly. Particularly, I suppose most of the participants that I was using, I had involved in my study were mild stroke survivors, so they were able to sort the 82 cards out within a couple of minutes. And it actually gave them a really good sense of what they were doing, because as I said before, you sort the cards out into the 5 different categories, and then they could see that, you know, the continue to do pile was quite big. The beginning to do was, you know, okay, but the given up perhaps was quite small. So that actually had another impact. So it wasn't just looking at the score that we were ultimately looking for. It also gave them that visual
feedback.
Yeah, exactly, for them to see where they felt they were. The other benefit of the activity card sort is that it has been validated in an Australian population, so I think that's really important, particularly if we're thinking about participation being a concept that must be embedded within the environment. So having something that has been validated in Australia, I think, is very important. In terms of quantitative measures of depression, I think there are lots and lots of tools out there, and it really depends on your service, because I know this is something that we've been thinking about at St Vincent's too, is using a really quick measure, particularly early on after stroke, so even in that really acute phase. And I know there hasn't been anything validated as yet at that really acute, you know, within the first couple of days post-stroke. So it really does depend on your population. I know the geriatric depression scale is often used, and and not just used for older people. It's used across the population and mainly because that's been validated in the hospital setting. So I think you need to look at where the tools have been validated, and particularly in terms of cultural, whether it's culturally relevant, but also in terms of the settings as well. So I can't really just say one measure over another in terms of depression. And then the other measure of participation that I think is quite good is the work and social adjustment scale, being one that was done, that can be done quite quickly within a couple of minutes. And I know, particularly coming from a hospital setting, that time is crucial, so we are wanting measures that are quick. But on the other hand, if you're using it as an intervention, well, using it as a tool to aid your intervention, then perhaps having something that's really quick perhaps isn't the answer as well. So it has to be part of, we have to consider the measures that we're going to use in terms of the setting that we're in.
And I know from the perspective of measuring depression, we've had Toby Cummings give whole presentations just on that one issue. It's a very complex area and also relevant to time points,
Yes.
how far after the stroke and what communication issues there might be and things like that as
That's
well.
right.
So it's a very
Yes.
complex area.
Yes. Yeah.
So we would welcome any more questions from the group. If there's anything else that people would like Tamara to cover, please do pop some notes into the box, into the chat box. Otherwise, we do, as I said, encourage you to complete that exit survey. And just to talk briefly about our April webinar, we will have Associate Professor Bruce Campbell speaking to us in April about hyperacute and acute stroke management. And we're looking forward to that. And if you're wanting to get in touch with the network in a more active way, we are certainly active on Twitter now, so you can find out what the network's doing by searching for the hashtag VSCN or connecting with my Twitter account at Sonia Denisenko or at Safer Care Victoria, which is the branch of the department that we're now part of. So please do get in touch that way. And Tamara, just another plug for the Chronic Stroke Review Toolkit. I'm really pleased to hear that that's going live this Friday. So that was a funded project by the VSCN, and we're really looking forward to people being able to access that. And that's part of that's going to be hosted on the Inform Me website by the Stroke Foundation. So it's been quite a lengthy piece of work and has sort of had multiple iterations in terms of a paper version and being tested with focus groups and things like that. Is there any other comments you have about that tool and how it might be useful to clinicians once it goes live on the web?
Yes, well, it really relates to my study because one of the focuses is on participation and a key element being that, well, I suppose it's a tool to help guide intervention as well post stroke, and one of the key tools is to identify those goals or client-centered goals, and I think that's really important, and participation being something that is really important as well, depression, so it really relates to my work. But just in terms of interventions, I haven't spoken about interventions and how to address participation here, but the Chronic Stroke Review tool has a component that focuses on the intervention. So if people are interested, it would be a great resource to have a look at.
Fantastic. Well, we'll look forward to that going live on Friday, and I'll certainly be tweeting about that once it's available to the stroke community via Inform Me. Well, thank you again, Tamara, for your time this afternoon, and thank you to our participants for listening in. And we look forward to hopefully having you participate again at our next webinar in April. Thank you.